pharmacology of drugs used in treatment of heart failure. So let's get right into it. Heart failure is simply defined as a chronic progressive disorder in which the heart muscle is unable to pump enough blood to meet the body's needs. In a normal heart, the upper chambers called the atria and the lower chambers called the ventricles squeeze and relax in turn to move blood through the body. Now, blood flows through the heart and lungs in four major steps. First, the oxygen-poor blood that has already circulated through the body is received by the right atrium, which in turn pumps it over to the right ventricle. Secondly, the right ventricle pumps the blood through the pulmonary artery into the lungs, where it picks up oxygen. Thirdly, the pulmonary vein empties oxygen-rich blood from the lungs into the left atrium, which in turn pumps it to the left ventricle. And finally, the left ventricle pumps oxygenated blood through the aorta to the rest of the body. Now, the Frank-Starling law of the heart is a basic physiological principle that describes how the heart is able to move blood through the body in a regulated way by pumping out as much blood as it receives. Specifically, this law states that increased filling of the ventricle results in greater contraction force and thus a rise in the cardiac output. In heart failure, however, this mechanism fails, as the ventricle is loaded with blood to the point where heart muscle contraction becomes less efficient. Now, depending on the primary cause, heart failure can manifest itself as either systolic or diastolic dysfunction. In systolic heart failure, the heart muscle becomes weak and cannot squeeze as much blood out. Poor ventricular contractility leads to reduction in the amount of blood pumped out of the ventricle, which we refer to as ejection fraction. While the normal ejection fraction can range between 50 and 75%, heart failure due to systolic dysfunction is typically associated with an ejection fraction of less than 40%. For this reason, the systolic heart failure is most commonly referred to as heart failure with reduced ejection fraction. On the other hand, in diastolic heart failure, the heart squeezes normally, but becomes stiff and cannot adequately relax to allow for normal ventricular filling. As a result, patients with diastolic heart failure have a relatively normal ejection fraction, although stroke volume and cardiac output are reduced. Because of this, diastolic failure is most commonly referred to as heart failure with preserved ejection fraction. Now, in the presence of heart failure, in order to counteract the effect of falling cardiac output and thus reduce perfusion to vital organs, the body will try to compensate via two tightly regulated mechanisms. The first one involves the increase in sympathetic nervous system activity. In the face of a reduced cardiac output, the arterial baroreceptors located in the aortic arch and carotid sinus will sense changes in blood pressure, leading to the release of norepinephrine that in turn stimulates beta-1 receptors located in the SA node, myocardium, and the ventricular conduction system. Stimulation of these receptors increases heart rate and cardiac contractility, leading to greater stroke volume. Because heart rate and stroke volume are components of cardiac output, which is simply equal to the product of the two, when they both increase, cardiac output will also increase to maintain adequate blood pressure and thereby perfusion to vital organs. Moreover, increased sympathetic nerve traffic to the kidney also activates beta-1 adrenergic receptors located on juxtaglomerular cells, causing them to release an enzyme responsible for regulation of blood pressure and volume called renin. And this brings us to the second major compensatory mechanism, which involves activation of the renin-angiotensin-aldosterone system. So in addition to sympathetic nerves directly stimulating renin secretion via beta-1 receptors, the release of renin from the juxtaglomerular cells is also regulated by two other primary mechanisms, which are the renal vascular baroreceptors that stimulate renin secretion in response to low renal perfusion pressure, and the macula densa cells of the distal nephron that stimulate renin secretion in response to fall in sodium chloride concentration. Now, once released into the blood, renin acts upon a circulating substrate that is primarily supplied by the liver called angiotensinogen to produce angiotensin I. On passing through the pulmonary circulation, angiotensin I is converted into angiotensin II by another enzyme, which is abundant in the lungs called angiotensin converting enzyme, ACE for short. Now, circulating angiotensin II exerts its action by binding to various receptors throughout the body, with most of its effects being mediated via angiotensin II type 1 receptor, abbreviated as AT1. These include stimulation of AT1 receptors in the endothelium of systemic arterioles, which leads to vasoconstriction, stimulation of angiotensin receptors in the brain, which causes the pituitary to release antidiuretic hormone, ADH for short, which in turn binds to specific vasopressin 2 receptors in the collecting ducts of the nephron and promotes reabsorption of water back into the circulation. And finally, angiotensin II also acts on the angiotensin receptors in the adrenal cortex to stimulate the release of steroid hormone called aldosterone, which in turn binds to nuclear mineralocorticoid receptor within the cells of the distal tubule and the collecting duct, where it increases expression of genes that encode epithelial sodium channels and the sodium-potassium pump, thereby promoting sodium and water reabsorption and potassium secretion, causing increase in plasma volume and blood pressure. Furthermore, vasoconstriction and fluid retention elevates venous and capillary hydrostatic pressures, forcing additional fluid out of the blood into the tissue, leading to edema, particularly in the feet and legs. The increased peripheral resistance and greater blood volume also place further strain on the heart and accelerate the process of damage to the myocardium, leading to structural cardiac remodeling. At this point, in a final attempt to maintain circulatory system homeostasis, the body will try to counterbalance overstimulation of the renin-angiotensin-aldosterone system and sympathetic nervous system by activating cardioprotective natriuretic peptides. Specifically, in response to increased myocardial stretch and volume overload, atria begin to secrete A-type natriuretic peptide, ANP for short, and ventricles begin to secrete B-type natriuretic peptide, BNP for short. And in response to increased levels of pro-inflammatory mediators resulting from cardiac injury, vascular endothelial cells begin to secrete C-type natriuretic peptide, CNP for short. Now, the main role of these natriuretic peptides is to counter the effects of volume overload and adrenergic activation by stimulating sodium and water excretion, promoting myocardial relaxation, inhibiting cardiac hypertrophy and fibrosis, suppressing sympathetic outflow, and stimulating vasodilation. However, in the end, even this counter response is not enough to save the failing heart. As heart failure advances, further activation of the renin-angiotensin-aldosterone system and the sympathetic nervous system ultimately overcomes the short-lived beneficial effects of the natriuretic peptides. And this brings us to the second part of this lecture, that is the treatment of heart failure. Now, the pharmacological management of patients with heart failure is complex and may require the use of several classes of drugs. So now let's discuss these one by one, starting with beta blockers. So beta blockers work by binding to beta-1 receptors in the heart and subsequently blocking the action of norepinephrine, thereby reducing heart rate and contractility, which in turn decreases cardiac output and blood pressure. As a side note here, keep in mind that decreased heart rate allows more diastolic filling time, so the stroke volume is typically not reduced. Now, similarly, via blockade of the beta-1 receptors of the renal juxtaglomerular complex, certain beta blockers may also reduce renin secretion, thereby reducing the severity of angiotensin II-induced vasoconstriction, as well as aldosterone-induced volume expansion. It's important to remember that this, however, is not beta blockers' primary mechanism of action. Among several beta blockers on the market, currently only 3 have proven to reduce mortality in heart failure patients. These are bisoprolol, carvedilol, and metoprolol. Out of these 3, carvedilol has unique pharmacological property in that it not only blocks beta-1 receptors in the heart, but also alpha-1 receptors located on the smooth muscle of the arteries and veins. By preventing norepinephrine from activating the alpha-1 receptor, carvedilol causes vessels to dilate, thereby reducing total peripheral resistance. Alright, moving on to the next class of drugs for heart failure, that is angiotensin-converting enzyme inhibitors. Drugs in this class selectively inhibit the angiotensin-converting enzyme, which in turn reduces angiotensin II production and its effects on vasoconstriction as well as ADH and aldosterone secretion. In addition to this, inhibition of ACE increases levels of a potent vasoactive peptide called bradykinin. Unlike angiotensin II, which is a vasoconstrictor, bradykinin is an endogenous vasodilator, which is normally degraded by ACE. So when ACE inhibition occurs, while angiotensin II levels drop, bradykinin levels rise. As a result, the blood vessels become dilated, total peripheral resistance is reduced, and blood pressure is lowered, thereby reducing the effort needed to pump blood around the body. Drugs in this class include captopril, enalapril, fosinopril, lisinopril, quinapril, and ramipril. Another related class of drugs called angiotensin receptor blockers, ARBs for short, also works on the same angiotensin pathway. However, instead of blocking the enzyme that drives angiotensin II production, ARBs work by binding to AT1 receptors located on vascular smooth muscle as well as other tissues such as heart, directly blocking the actions of angiotensin II. As a result, the effects are similar to ACE inhibitors, that is, less vasoconstriction and less ADH and aldosterone secretion, which lowers blood pressure and ultimately prevents damage to the heart and kidneys. Also, because ARBs do not inhibit ACE, they do not cause bradykinin levels to rise. This makes ARBs a good alternative to ACE inhibitors, as more bradykinin not only contributes to the vasodilation, but also contributes to some of the side effects of ACE inhibitors, such as cough and angioedema. Drugs in this class include candesartan, losartan, telmisartan, and valsartan. Now, despite being treated with an ACE inhibitor or angiotensin receptor blocker, many heart failure patients continue to suffer from cardiovascular events. As a result, increasing the beneficial effects of natriuretic peptides has gained significant interest as a therapeutic approach in the management of heart failure, leading to development of a new class of drugs called angiotensin receptor neprilysin inhibitor. Now, neprilysin is a circulating enzyme that degrades several endogenous vasoactive peptides, including ANP, BNP, and CNP, and thus terminates their positive actions. Angiotensin receptor neprilysin inhibitor simply combines angiotensin receptor blocker and neprilysin inhibitor to simultaneously block angiotensin II receptor as well as inhibit neprilysin enzyme, thereby preventing it from breaking down natriuretic peptides. This results in an increased longevity of natriuretic peptides as well as enhancement of their beneficial effects. The example of drug that belongs to this class is sacubitril valsartan. Now, another shortfall of ACE inhibitors and angiotensin receptor blockers is that in some cases they don't suppress the excessive formation of aldosterone sufficiently. Therefore, select patients with moderate to severe heart failure can also benefit from another class of drugs called aldosterone antagonists. Aldosterone antagonists work by competitively blocking the binding of aldosterone to the mineralocorticoid receptor, thereby decreasing the reabsorption of sodium and water as well as decreasing the excretion of potassium, leading to cardioprotective effects. For this reason, we also refer to this class of drugs as potassium-sparing diuretics. The examples of drugs that belong to this class are eplerenone and spironolactone. Now, although aldosterone antagonists have been shown to lower blood pressure and exert some diuretic effect, in order to alleviate symptoms of volume overload, a more potent class of drugs called loop diuretics is needed. So the primary use of loop diuretics is to relieve symptoms associated with pulmonary congestion and peripheral edema. Loop diuretics achieve this by inhibiting the luminal sodium-potassium chloride cotransporter located in a thick ascending limb of the loop of Henle, where about 20 to 30% of the filtered sodium is managed. As a result, in contrast to other diuretic agents, loop diuretics reduce reabsorption of a much greater proportion of sodium. This sodium is then excreted along with the water that follows it, leading to significant decrease in plasma volume, cardiac workload, and oxygen demand, thus relieving signs and symptoms of volume excess. Drugs that belong to this class include bumetanide, furosemide, and torsemide. Now, in some cases, when a patient is truly intolerant of ACE inhibitors or angiotensin receptor blockers, usually because of significant renal dysfunction, the blood pressure can be controlled with another class of drugs referred to as vasodilators. There are two drugs in this class that are typically used in treatment of heart failure. The first one is isosorbide dinitrate, which releases nitric oxide in the vascular smooth muscle cell that subsequently activates guanylyl cyclase, an enzyme that catalyzes the formation of cyclic guanosine monophosphate, cGMP, from guanosine triphosphate, GTP. Increased intracellular cGMP in turn activates a series of reactions that cause decrease in intracellular calcium concentrations. And because calcium drives the contraction, this decrease ultimately leads to smooth muscle relaxation and thus vasodilation. Now, in contrast to isosorbide, the second drug, that is hydralazine, appears to have multiple effects on the vascular smooth muscle, which include stimulation of nitric oxide release from the vascular endothelium, stimulating cGMP production and decreasing calcium concentration, opening of potassium channels, and inhibition of calcium release from the sarcoplasmic reticulum, which altogether contribute to smooth muscle relaxation and subsequent vasodilation. Finally, before we end, I wanted to briefly mention one more drug that can be used in management of heart failure, particularly in patients intolerant to ACE inhibitors or beta blockers, that is, digoxin. Now, the mechanism of action of digoxin is sort of the opposite of the vasodilators one, in that it is used to increase cells' contractility, specifically the contractility of cardiac muscle cells. Digoxin accomplishes that by inhibiting the sodium-potassium ATPase, which is responsible for moving sodium ions out of the cell and bringing potassium ions into the cell. As a result of this inhibition, when sodium concentration in the cardiac cell increases, another electrolyte mover, known as sodium-calcium exchanger, pushes the excess sodium ions out while bringing additional calcium ions in. This in turn causes an increase in the intracellular calcium, which is then available to the contractile proteins. The end result is increased force of contraction and thus increased cardiac output.